Please go ahead.
Good morning. We are really delighted to have you with us today to participate and share in our first annual Global Surgery Symposium. I'm Stephen Roser. I am one of the leads in global surgery in the Department of Surgery and the Emory Perioperative Global Alliance, and welcoming you today. That so many of you are joining us at times early in the morning or late in the evening serves as a reminder to all of us how important our work is. The Emory Perioperative Global Alliance, which is sponsoring the symposium, is committed to the goal of safe surgery, anesthesia, obstetric, and trauma care for all. This goal cannot be achieved by one group of people alone. In this spirit, the theme of this symposium is interprofessional collaboration in global surgery. We're honored today to have Dr. Robert Riviello as our keynote speaker. Dr. Riviello has worked many years in many places to train people to build capacity in low-resourced areas. I'm very excited about our program. Today we have a number of speakers from around the world presenting on such subjects as perioperative rural care, maternal health, cancer care, and trauma care in low-resourced areas. Also included in this presentation is a discussion on careers in global surgery. Tomorrow, we will host panels of trainees and a poster session talking about their experiences with global surgery. Built in on both days, or into both days, will be networking in breakout rooms, which I hope you'll all take advantage of and get to know the other participants. Before I hand over to Dr. Allison Linden, who's going to introduce our keynote speaker, I would like to have Dr. Constance Schreckengoss, one of our Emory General Surgery residents and a Global Surgery Research Fellow this year, talk about the agenda and provide direction to you how to navigate through the day. Thank you, and Constance.
Welcome everyone to Emory University's inaugural Global Perioperative Health Symposium. I'm Constance Schreckengoss, a general surgery resident here and a Global Surgery Research Fellow. I'll be giving you an overview of the schedule for the next 2 days and also helping you navigate through the sessions. First, here's our schedule for today. As you know, we start with our keynote by Dr. Robert Riviello. This will be followed by 2 panel sessions, one focused on locally global actions, as well as another one focused on maternal health and the role of interprofessional collaboration in maternal health. This will be followed by 3 networking sessions that you can choose among. Each networking session will last for 30 minutes. In the afternoon, we have another 2 panels, one on surgical oncology and another on trauma. We close out the day with another 3 networking sessions. Next, on Sunday, we start our day with a panel session by trainees at the undergraduate, medical student, and resident level. We then have a 2-hour poster session with presenters from around the globe. We'll then have another networking session where you can talk to the presenters from the morning sessions in a little bit more detail. In the afternoon, we have a session with speakers talking about different kinds of careers and fields and the ways they got involved in global surgery. Finally, we'll have our award session and closing remarks by our chair, Dr. Roser. And at the end of the day, for those who'd like a little bit more, you can stick around for some of our other final networking sessions. If at any time you'd like to review the schedule in more detail, please just go to our website. You can always Google Emory Perioperative Symposium and you'll find the website there. Next, how do we get around the sessions today? If you're already here, you've probably found our broadcasting page. In order to join the sessions or any of the main sessions, you'll want to click this live button. Since our speakers come from all over the world, you'll note that some of our sessions are pre-recorded and some are live. We appreciate your patience as we navigate between the different kinds of sessions. To ensure that our speakers can be heard, attendees will not have voice or video capability during the main sessions. However, most sessions do have Q&A components. If you'd like to ask a question or make a comment, please post questions to the chat where the moderator can see them. You will be able to talk and see each other during our networking sessions. We hope you take advantage of these times to meet each other and continue the discussions. To join a networking session, click on the networking room you'd like to join that's at the top of the page underneath the live button at the appropriate scheduled time. We hope you enjoy the symposium, and if you have any concerns, please email info@slidespiel.com. This address is also available on the main broadcast page. I'll now be turning it over to Dr. Allison Linden, who will be presenting our keynote speaker, Dr. Robert Riviello.
Good morning, and welcome to the first Emory Global Perioperative Alliance Symposium. I'm Allie Linden, a new faculty member within the Department of Surgery, Division of Pediatric Surgery. It is an incredible honor to introduce the keynote speaker for the conference, Robert Riviello. He has been an inspiration to me since even before I first met him over 11 years ago. He became a close mentor during my research years as a global surgery research fellow at Harvard, and subsequently has become a dear friend as we've spent time together both in the US and abroad, significantly in Rwanda. He graduated cum laude from Harvard College, attended medical school at the University of California, San Diego, obtained his MPH from Harvard University, and completed his general surgery residency at Vanderbilt. He finished his advanced training at Brigham and Women's Hospital in Boston, completing an acute care, burn, and critical care fellowship. In regards to academic global surgery, he has truly blazed the trail for our coming generation. He has formally mentored over 35 U.S. and international residents and medical students in global surgery. He has been awarded private, public, and NIH grants for global surgery projects and currently has an endowed chair in global surgery. More importantly, he is just as recognized internationally in the surgical community and is a fellow of the College of Surgeons of East, Central, and Southern Africa, an advisory council member of the Pan-African Academy of Christian Surgeons, and is a member of the Rwanda Surgical Society. Further, he is a professor of surgery at the Rwanda University of Global Health Equity. It has been his goal to improve surgical delivery in low-income settings and to create opportunities for others to study and contribute to the field. Accordingly, he is the founding director of the Brigham and Women's Department of Surgery Global Health Equity Residency Tract. In addition, he is the director of global surgery at the Brigham and Women's Hospital Center for Surgery and Public Health and the deputy director of the Harvard Medical School Program in Global Surgery and Social Change. For the immense amount of work he has contributed abroad and to creating the field of academic global surgery, he was awarded the International Surgical Volunteerism Award from ACS in 2020. Beyond his accomplishments on paper, Robert is truly one of the most genuine and optimistic people I will ever meet. He is empathic and has a genius for ideas and problem solving. His energy is endless, as is his excitement to meet and mentor another community in global surgery. Welcome to Emory, Robert. We are so lucky to have you with us.
Good morning. Thank you for having me here. I'm delighted to be invited and be able to start off this conference on global perioperative care, collaborative care and global perioperative symposium. Thank you, Dr. Roser. Thank you, Dr. Linden, and the whole organizing committee for having me. My talk is entitled Interprofessional and Intra-professional Collaboration in Global Surgery. I have no disclosures. So I'd like to start with this notion of storytelling. The author and novelist, Chimamanda Ngozi Adichie, pictured here, starts off this really impactful TED Talk of a lecture given in Oxford in 2009 with the declaration, "I am a storyteller." I also think of myself as a storyteller, not with the talents that Adichie has, but this is a very powerful talk she gives. The title of her talk, I want you to notice, is The Danger of the Single Story. In this lecture, Adichie tells a story of how she found her own authentic cultural voice and warns that if we only hear a single story about another person or another country, we risk critical misunderstanding. I encourage you to listen to the entire talk. It is 20 minutes of your life that is profoundly worth it. I'm rather self-aware that I am presenting today as the keynote speaker for a global health conference at an internationally renowned university, and I have all the trappings of academic neocolonialism: white, male, Harvard, work in Africa. And I'm aware of that, and we'll come back to this. The title of my talk today is Interprofessional, and Intra-professional Collaboration in Global Surgery. By the nature of the topic alone, there have to be many voices to tell the story well and to tell it correctly. I aim to bring in as many voices as I can, knowing that I can, that I know, and that I've heard. This talk will be less of a presentation of data. There will be some qualitative, some quantitative data, but really this is more a bit of storytelling. All of these stories, 4 or 5 of them, are set in Rwanda. Stories that have taught me a lot on this topic. I'll reflect on the lessons learned from the stories, and importantly, reflections learned by my teachers in these stories. So with that, let's begin. I first got to Rwanda in 2009 when I was a new fellow here at Brigham Hospital, and was quickly connected to the organization Partners in Health, or in Kenya, Rwanda, in Buzima, where I had the opportunity to work at a number of 3 district hospitals, Ministry of Health district hospitals that Partners in Health supports. The one pictured there is Butaro Hospital in the far north. At the time, it didn't look quite so nice. It was really just a repurposed really military bunker that then has become this incredible location. Initially, I was there 3 months yearly, and as a relatively new surgeon, had years of experience in Angola, but Rwanda was new to me, and the context of the district hospital was new to me. That is me operating with Dr. Juvenal Musavuli. Juvenal was at the time a general practitioner from the Congo, working in the far north of Rwanda, but a deep passion to become a surgeon. I'm happy to say that he has achieved that aspiration. He trained through the Pan-African Academy of Christian Surgeons program in Niger and is now working and serving as a surgeon in a hospital in Liberia. I learned in that time of working with the surgical providers of the district hospitals that, unlike my previous experience in Angola, all the surgical providers in district hospitals are not surgical specialists. In the Rwandan case, they are general practitioners, GPs, finished medical school, and no further formal surgical training. This is my first contextual learning. Next piece, these two in the photo, that's Dr. Eric Laganisi and Dr. Gita Modi. Eric was also, at the time, a GP at Rinkwavu District Hospital, who also had a passion for surgery, and he and I had done lots of hernia repairs, and he wanted to learn pediatric hernia repairs, and we did those together in a supervised fashion. And a couple years into this story, Dr. Modi, Gita Modi, who is now a thoracic surgeon at UNC Chapel Hill, at the time was a surgical resident, spending her global surgery focused research time in Rwanda. Here she is learning to do pediatric hernias under the direction of Eric, who had quite perfected it. Now, the interesting thing was when not there, Dr. Eric wouldn't perform any pediatric hernias on his own appropriately because he wasn't credentialed or certified in the system. He was competent, but didn't have a mechanism to do so safely in a medical legal practice. A few other things this taught me. One, once again, understanding the context, not only of how the district hospital works, but how those individuals in the district hospitals feel they can or can't work really matters. Secondly, this the power of the cross-cultural collaboration was tremendously impactful for me here. While there, in those years also, we had the opportunity to listen to the hospital directors to the nurse in charge of the hospital, nurse in charge of the surgical wards. And one of their concerns was, we have so many patients with chronic wounds who are here for weeks to months. And in so doing, surgical beds are tied up. And in so doing, surgical procedures can't be done because there's no post-operative bed to put them in. Is there something we can do? This created the opportunity to partner with a PhD student at MIT to work on this, what we call the wound pump, which is a simplified negative pressure wound therapy device, with that goal of addressing that concern raised by the nurse director and the hospital directors of hospital throughput. It's a great chance to innovate, but the innovative spark came from listening to the local needs. And lastly, those years of being there, coming back again and again, 3 months a year, allowed me to connect with the Inshuti Mubuzima leadership, with the hospital directorship, and over time develop relationships based on trust that in the years to come would allow other ideas to flourish. These early years for me with PIH in Rwanda, I didn't know at the time, laid a lot of the groundwork of many of the lessons that would come to fruition in the next several set of stories. So, next story. Next story is that of the Rwanda Human Resources for Health program, or HRH. This was, as you can see, from the years 2012, 2019, extended into 2020, a massive undertaking. This was a program of the Ministry of Health of Rwanda that was funded by PEPFAR, the President's Emergency Plan for AIDS Relief, through the US CDC, together with the Global Fund, for the funding piece of it, to generate a collaboration with a number of academic medical centers in the US who would contribute visiting faculty who would move to Rwanda and integrate themselves into the University of Rwanda's College of Medicine and Health Sciences and other specialties for a number of goals. And essentially those goals were to scale up the training of and the quality of the training of several healthcare cadres, doctors, nurses, health managers, and dentists. A very large multi-professional training program. Costed out about $150 million over the course of 7 years through the Ministry of Health of Rwanda, with proximal goals of training more human resources and more distal goals of strengthening the University of Rwanda's capacity to continue making those human resource gains independent of foreign aid at the end of those 7-8 year period, all towards the sustainable development goals of good health, quality education, and partnerships. So what did that look like? At the beginning of the program, 2013, in this New England Journal article, those projected numbers, the targets were put out there for all those different cadres. But as an example, for the docs, the goal was to take a country that had 600 docs and almost double that to basically 1,200 docs. And importantly, to take that specialization rate from a quarter of the docs who finished medical school, went to residency, to increase that to 50% of them. And similar goals in nursing, health management, and dentistry. So the sustainability strategy of that was basically small invasion, if you will, of U.S. faculty or faculty through U.S. institutions to integrate into the University of Rwanda. It then, in a collaborative fashion, strengthen the training programs that would generate more and more human capacity, human resources, and amongst those, Rwandan faculty would be developed such that as the number of U.S. faculty weaned down, the number of Rwandan faculty were developed. And as Rwanda looks back on this program, they can say with a certain amount of confidence that those goals were achieved. You can see there was U.S. faculty from, again, multi-professional doctors, nurses, oral health, and health management, a large bolus at the front end, and then petering off towards the end of the program. And in each of these cadres, we saw growths of the trainees. These are the doctors that were specialist doctors that were trained across internal medicine, surgery, anesthesia, obstetrics, radiology, pathology, neurosurgery, urology, orthopedics. I'm probably missing one or two more. Similar trend with nurses, much larger numbers, up to 5,000 new nurses, oral health professionals in a program that had institution that had very, very small training output, nearly quadrupled their output per year. And then health management, which did not have an existing training program. All of these had that growing number. At the end of the day, this program was all about the graduates. It was about those trainees that got skills, got encouragement, got support, hopefully vision for Rwanda's future through the program. This is the first class of surgeons graduated who had completely trained in the University of Rwanda when it was supported by the HRH program. About the same time, obviously these were almost all men. There's a burgeoning number of women interested in surgery. This was the flanking Dr. Nies Benegwaho, the Minister of Health at the time, were students and residents in surgery preparing to travel for the first Women in Surgery Africa meeting, which that year was in Malawi. Actually, as I look at this photo now, these women now represent Rwanda's first female general surgeons, orthopedists, urologists, and plastic surgeons. Now, one of the things here that we don't see is that I talked about a multi-professional training platform. Doctors are trained, nurses are trained, health managers are trained, and oral health providers are trained. That I would call a multi-professional training program, but we weren't very much an inter-professional training program as we look back. And frankly, again, in the middle of the photo here, Dr. Nies Benegwaho, in 2011, even before the HRH program got launched, the surgeons in Rwanda and the surgeons attached to the Rwanda Surgical Society, Rwandan and foreign, had gotten together for a planning retreat for how to develop surgical programming, human resources, infrastructure, service lines, etc., and presented these plans to Dr. Benegwaho. And her response to that essentially was, "This is great. Now all you surgeons go out and help your colleagues, pediatricians, internists, anesthesiologists, obstetricians, nursing, to do the same." And I know for me, and I think for many in the crowd, that felt like an overwhelmingly daunting task, and frankly wasn't our initial plan. But way back then, the request for intra-professional planning had already been there. We didn't achieve that, I don't think, as profoundly as we would have hoped with the HRH program. However, I think the groundworks were laid. As I look back on the HRH program, I think some of the lessons we learned here were things like, this work is hard. It takes a long time. So have the long view, own the frustrations, because it's worth it. I'm going to now jump to a third story. This is a story about non-technical skills in surgery, or NOTS. NOTS is a training program, or it's really an assessment tool that started in Scotland that looks at quality in surgery. So it turns out that probably 50% of complications of operations are due to failures in non-technical skills. Non-technical skills are those cognitive and social skills that underpin excellent work, often teamwork. And so this graphic here gives you a sense of them. Situation awareness, like information gathering, understanding information, and projecting a future state. Decision-making, communication, teamwork, and leadership are all non-technical skills that the NOTS framework has identified. So during the time of the HRH program, Dr. George Takiruta, pictured here, who is the head of Department of Surgery for the University of Rwanda, was visiting Scotland on a grant to help support the establishing of a simulation center at the University of Rwanda. And of the many things he saw, he came across this concept of NOTS, non-technical skills for surgeons. And he said, we need this in Rwanda. And we need this in a way that is contextually relevant to the Rwandan context. Rwandan looking ORs, Rwandan epidemiology, Rwandan resources. This course is often taught using a series of videos of simulated operations. And so this group came together to film on site at the University Teaching Hospital of Kigali a number of teaching cases. And so surgeons and surgical residents, anesthesiologists, anesthesia residents, anesthesia technicians, perioperative nursing staff got together and did these 4 phenomenal teaching cases to teach the surgeons. And then the group said, wait, but we all work as a team to deliver surgery. Shouldn't this be a training course for all of us to work interprofessionally? And instead of just teaching the surgical residents, shouldn't we teach surgical residents and the anesthesia residents and the obstetrics residents and the nursing staff together so we can learn together? And that led to a series of courses through the University Teaching Hospital in Kigali and the University of Rwanda. This was the 2nd annual course. In the front here, I don't know if my pointer is showing up, Ajida Bahuje was one of the actors in and now has been one of the champions of the NOTS program. And right next to him is Allie Linden, who recently arrived here at Emory, and thank you for the introduction a few minutes ago. This was a wonderful day of discussions at a super comfortable hotel in town, and everybody had a great time. The feedback, both sort of ad hoc and qualitative, was this is great. It's good to work interdisciplinarily, interprofessionally, and to learn from each other and to learn in the same setting. And 80% of surgery in Rwanda, like a lot of similar settings, happens not at the University Teaching Hospital, not at the capital, not with specialists, but at the district hospital, with non-specialist trained people in our fields, in surgery and anesthesia and nursing. Shouldn't this training happen in those settings? And so that gave the opportunity to develop the NOTS, non-technical skills for surgery, REST, Rwanda Essential Surgical Training Program, linking 2 training programs that were outreaches into the provincial and the district hospitals to help build up and support perioperative skills at the district hospitals. So this photo is just that. This instructor here is an anesthesiologist and at the teaching hospitals, who is also an instructor for the NOTS course, debriefing at the end of a day of surgery with the OR staff at one of the district hospitals. That includes GPs who do surgical procedures, anesthesia technicians who work with them, and the perioperative staff at the district hospital. This program rotated around the country to create opportunities for staff from all the district hospitals. And it's progressed such that our hope is, or the NOTS team's hope is that this soon can be incorporated into the curricular expectations for COSEXA, the College of Surgery Central Southern Africa. When I look at what Rwanda, or the Rwandan experience in NOTS, has taught me, we started with a program that was really not technical skills for surgeons, a single profession course. But then advocates said, actually, we work multi-professionally. We had to make these videos together. So therefore, we should learn from each other interprofessionally. But then the reality is in this context, so much of the surgical delivery isn't from the specialists, it is from other cadres within our profession. So not always specialized surgeons, but general practitioners or surgical technicians. So within or intra the profession, we should also have collaboration and training. Next story with its set of lessons. This is now back to the Partners in Health, the PIH world. Also, back in 2011 or 12, I had the opportunity to meet Dr. Bethany Gauthier. Bethany is a faculty PhD biostatistician at Harvard Medical School, and who was also living in Rwanda for a number of years at the time. We deliberately formed a partnership to support and strengthen surgical research in Rwanda. We had the opportunity a few years later to respond to or request for proposals from the Fogarty Center around mobile health. We had a little bit of pilot data in Haiti and early experience in Haiti of supporting community health workers like these to follow patients at homes post-surgery around C-section care. And so this grant that a team of us put together, Dr. Bethany Het, Gauthier, Dr. Fred Katira, who was at the time the Chief of Research for Institut Mupuzima, IMB, and is now the Chief Medical Officer. And in this program, community health workers would visit post-C-section patients in their home, and they were empowered with a mobile device, initially a tablet, and then eventually a smartphone, that were equipped with apps that ran through a screening protocol and took a photo of their surgical incision, with the idea that perhaps we could identify surgical site infections at the home faster than routine care, which would be the mother returning to the community health center. Well, it turns out that moms already do return to health centers in a Rwandan setting pretty regularly, but we learned lots of other things. We learned that 11% at that time of C-sections were complicated by surgical site infections. We learned that there's a high proportion of antimicrobial resistance, even in these district settings. We learned that water, sanitation, and hygiene conditions, both at the hospital and in homes, needed work and were contributing to that SSI rate. We learned that even though mothers do get to the health centers for their post-op checks pretty routinely, that cost, that out-of-pocket cost, was putting a number of families into catastrophic health expenditures. And finally, we also learned that, not surprisingly, but we could document that women who lived further from the district hospitals were less likely to come back for care and were more likely to have complications. Finally, getting back to this initial notion of whether a community health worker visiting the mother at the home with a phone could help identify surgical site infections faster, it allowed us the opportunity to partner with PhDs in computer science, machine learning, and artificial intelligence to say, can the app be taught through this bank of images to identify those SSIs, as well as a doc at the other end of the phone taking a look at the photo. And it's been a great learning tour into something I didn't know anything about, machine learning and artificial intelligence. And perhaps even better than that learning tour was the group that we got to work with. In this photo, there's representatives from Partners in Health, from the University of Global Health Equity, from MIT, from the Ministry of Health, from Brigham Hospital, from Harvard Medical School. I think what I have learned from this setting is the challenge that we stretch our definition of interprofessional learning, not just within our perioperative circles, not just the anesthesia, nursing, and surgical providers, but also the PhD biostatisticians and the machine learning experts and the community health workers and the hospital directors, the motor taxi drivers, all have contributed tremendous things to our understanding of postoperative care for women undergoing C-section, which is the most common operation done in district hospitals, which is the place that does the most surgery in the country. So stretch those interprofessional definitions. One more thought from this organization, which was that same group, this is Bethany Gauthier over here, has led yearly, just about, operational research training programs and used the data from those studies to train first-time researchers from various Rwandan organizations, Partners in Health, University of Rwanda, and the Ministry of Health. I think the lesson here is use this, beyond stretching the notion of interprofessional, also always build capacity. We all have skills. We all have learned things. We may not be able to run a course yet, but we've learned. So pass on. Even as we're listening, also teach. And finally, in that notion of stretching interprofessional, advice I got years ago, and it's now starting to settle in, is go to each other's conferences. It's easy to stay in our comfort zone, in our surgery or our global surgery or nursing or global anesthesia conferences. Go to a machine learning conference. Nowadays, when we're all on Zoom, it's easier and easier to access new people and new ideas. So now the last story. This one doesn't have this is the only photo for this. UGHE, the University of Global Health Equity, is a relatively new university up in the northern hills of Rwanda, sponsored by Partners in Health and in association with those district hospitals that Partners in Health supports. I want to tell a story that profoundly impacted me. About a year and a half ago, in November, I was at University of Global Health, UGHE, for a day, and it just so happened that day was the launch of the simulation center, the Sim Center. And I'd really thought that was just going to be a ribbon cutting. And I was there with another group to look around, ask questions, meet people. And so I wasn't tremendously paying attention to that Sim Center launch. At some point, I walked by and realized that I was going by a lecture hall where somebody was teaching about ventilators and was talking about barotrauma and volutrauma, concepts that I talk about in surgical or in critical care. And I was impressed that was the topic that moved along. And then later in the cafeteria, somebody called me out by name. Hey, Dr. Robert, how are you? And out of context, it took me a while for my eyes to focus and figure out who I was speaking to. And he is a consulting or attending anesthesiologist now at the University Teaching Hospital of Butare in the south of Rwanda. I had known him when he was a resident training in Rwanda, in Kigali. Oh, what are you doing here? Happy to see you. I'm teaching at the course at the Sim Center. Oh, then my mind started to turn. And I realized what was going on is that the Sim Center launch was actually just its first course. And that course was a course for district hospital anesthesia technicians being taught by University of Rwanda physician anesthesiologists from the University of Rwanda, from the teaching hospitals, both at Kigali and Butare, in partnership with a company that creates ventilators, robust ventilators, ideal for this sort of context, at UGHE. And this was, for me, revolutionary. UGHE is a small, little, and beautiful university in the northern hills of Rwanda. So would its mission be all about the university, or would its mission be about equity? That line up there. Anesthesia technicians never, as far as I knew, ever get CPD, continual professional development. But 80% of surgery, as I've said, is at the district hospitals where there are no MD anesthesiologists. So many times the rate limiting step in terms of delivering surgical care is those anesthesia technicians. Either their availability, because they're overworked, or the complexity. Anesthesia technicians are not credentialed for delivering pediatric care. And so even a child who has a simple abscess often can't get care there, has to be shipped to a referring hospital. So who are the beneficiaries here? Well, the beneficiaries were the anesthesia technicians, who almost always get overlooked. The beneficiaries were the anesthesiology attendings or consultants, who were being both compensated at the time, appreciated for their expertise, and kind of brought to this essentially retreat center. The University of Rwanda and the University of Global Health Equity, in doing so, started forging alliances of mutuality and respect. The same ventilator company, they were both supporting the conference as well as looking for opportunities to expand their market. And ultimately, the country, and I hope the region, are the beneficiaries of this sort of equity-focused training that looked to say, who needs to be trained? And as I look at that, this means equity-focused training has to be intra-professional, meaning fairness in the training opportunities for those cadres within the profession, here, the anesthesia technicians, who, again, often get overlooked for training and yet provide so much of the care. And equity also means interprofessional, if we're going to deliver excellent care for impoverished populations who've often been overlooked, then we have to do that interdisciplinarily or interprofessionally. And so learning to do our care interprofessionally and training to do so is going to achieve higher qualities. So coming towards wrap up, as I've gone through these stories and thought about them, I hope there's a few lessons you've heard, and I'd like to touch on all of them here. So first one, starting back in early PIH days, start small, get to know people. Even if you are coming with a large organization, representing a large organization to a large organization, say Emory University, and in a training program with a large teaching hospital somewhere else or around the corner, as an individual, start small, get to know the people around you. That's where you're going to find some of your best ideas and wisdom. Listen to those local needs, like that local need at Rwanda Hospital of all those chronic wounds that need to get treated. If we seek first to understand, then we're likely to have better insights that are more impactful. Always come back to the local context. And I think this is an iterative process that we must do throughout our lives, whether it's at home or in our partnered relationships. Context is king. If we aren't addressing problems within the local context, then we're not doing anything useful. Take the long view. Own the frustrations. The challenges of care delivery and the quality of care delivered for the impoverished are real. They're entrenched. They have profound histories that causes that are deep in history and wide in geography. And understanding that means we have to take the long view to see benefit. That will come with frustrations. Own them. It's part of the work. Find and create interprofessional and intraprofessional opportunities. I don't think we get the opportunity to do both interprofessional and interprofessional every single time, but keep looking for them in each new project you undertake. Create hub and spoke models of working collaboratively. I failed to mention this earlier, but in a book entitled Deep Work by Cal Pinkerton, he describes what happened at the Bell Labs, the turn of the last century, in solid state physics, where people of various different disciplines, physicians, experimental scientists, physicists, experimental scientists, engineers, and others, were all in a common space, a hub and spoke model architecture building, where they could come together, share ideas, work together, and then go off to their spokes and work deeply within their discipline or their professions. I think similarly for us, we can't always be training all the time. I can't be learning PhD level biostatistics and optimal nursing care of patients while learning the crafts of surgery or leadership skills. That's true for all of us. We need to deepen our within our profession skills and also deepen our ability to work together in this kind of hub and spoke model. Stretch the notion of interprofessional. This I talked about quite a bit. Go to each other's meetings. Meet people who are different than you. Seek to understand different points of view, because we'll be better. And finally, this is the lesson from UGC. Think big. Synergize. Work towards equity. Find those spaces where we are better together to tackle the problems of equity. And on that last note, think big, synergize, work towards equity. I want to come back to where we started, with Chimamanda Adichie. She talked about the importance of who tells the stories, what stories are told. And I would be remiss if I didn't recognize that, in fact, I've been given this opportunity to be a storyteller. But there are many, many storytellers in this role. As I put this talk together, I recognized and regretted that I had not taken the opportunity to bring other voices actually into the story, into the storytelling. And we'll do so in the future. That would be equity, ensuring that the voices that know the stories are being told, are being heard, and that we're hearing many voices, so we don't fall into the danger of the single story. So let me do at least that. I've had many teachers, and I'm deeply grateful for all of them. All these people, my colleagues and friends, are just a slice of them. They each have a different way of telling the stories I just told. All of them are actors in these stories. They have various perspectives on the stories, and it's only in this diversity that we'll learn all that is needed and create meaningful impact, real good. It's not just my colleagues and friends, it's also the mentees. These mentees are deliberately paired across differences to learn from each other and to grow. These are mentees who provided insight and incredible work, honestly, for which I'm grateful. I think it is safe to say that all of us seniors among us recognize that none of the work we're talking about would occur without their engagement. I'm going to pause and also take a moment to say thank you to my mentors. In that top left corner, Dean Abebe Bekele and Dean Patrick Chimaniwa were both profs and deans at the University of Global Equity now and University of Rwanda formerly, respectively. They're tremendous leaders who drive real change. These three preceding slides, the people in these three preceding slides need to be the ones telling the stories. I think going forward from here, my personal commitment that I will ensure that the storytelling happens when I'm invited to tell a story, that I will tell it together with other storytellers. Finally, a word of thanks to my family who has gotten used to me being around more since COVID, and they're giving me some time off to join this great conference this weekend. So as we wrap up, let me just say thank you for attention. Wish you a tremendous conference going forward. Hope that you'll listen to each other and to the various stories being told so that we can be together, be better together, interprofessionally and intraprofessionally.
Thank you, Robert, so much for that really kind of inspirational, comprehensive talk about inter and intra-professional collaboration. I think you touched on so many different yet really salient points about kind of how these different collaborations have affected your professional and personal development throughout your career. I just had a few questions that I wanted to ask you as we were all listening to your presentation. Can you talk a little bit about when you were speaking about the HRH program, how do you make sure that the goals at the start of a project evolutionize or kind of meet the outcomes at the end of a project? You mentioned this was kind of one of the biggest challenges or lessons learned from HRH.
Thank you, Ali. And actually, since we're having a bit of a technical glitch, for those who are watching, the person just asking the question is Dr. Allison Linden, who's, I don't know if she got an intro at the beginning of this, is a pediatric surgeon recently arrived at Emory, and we've had the opportunity to work a lot in Rwanda. So thank you, Ali. To the question of how do you keep those goals front and center and evolutionize, I like the word, over the course of a program like the Rwanda Human Resource for Health program. And these are retrospective insights. It was a pretty complex program in the sense that there were many, many invested actors, or many, many individuals and groups that would be potentially impacted and could potentially invest in this. I think some of the lessons learned, we collectively learned midway and towards the end of the program is we did the quality improvement, take a look back and how would you improve. Some of the high points was before the program launched, there were a number of gatherings of leaders, stakeholders, etc. So representatives from the Ministry of Health, representatives from the various heads of programs at the university. Rwanda at the time was National University of Rwanda and a few other higher education public schools. and representatives from the U.S. institutions, both universities and academic medical centers. And so that allowed sort of some first setting out the major goals and then hammering out what some of the sub-goals will be into there. Frankly, the time that I met a number of well, it's not the first time, but for many, what I was going to say is the time I met a number of the leaders of surgical training in the country. That was certainly true across other disciplines as well. Pediatrics, internal medicine, obstetrics within medicine, and within other cadres, nursing, etc. There was a similar sort of first date, if you will. I think something that that the collective we could have done better to roll out the ministry's objectives is to make sure that that dialogue beforehand wasn't trickled through all of the potential beneficiaries and actors in a program like that. So the heads of departments and the heads of programs of the ministry were part of these discussions. The folks who didn't get the opportunity to hear those discussions were those faculty who would be twinned. So U.S. faculty getting recruited in and Rwandan faculty that would be working together with U.S. faculty so that there could be an exchange of content and context between them. We realized after the fact that there was misunderstanding or incomplete understanding of the program's goals, and so there were a few resets over the course of those 7 years to help whether get back on course or identify still aligned but slightly different targets. And I think the reality testing made implementation better. At first, the idea was one-to-one, one U.S. faculty paired with one Rwandan faculty, and that wasn't always practical. You couldn't actually make that really happen. But it might be a U.S. faculty partnered with a department, or it might be a couple or three faculty partnered with across methodologies and research training, etc. I hope that helps answer what you're getting at. I think in summary, put forth our best efforts to ensure that the message spreads to all the people who will be impacted by a program like this, and have iterative rechecks again, sort of classic quality improvement methodology.
That's great. Thank you. I think you just mentioned a lot of really kind of helpful areas, so to speak, of collaboration at different levels. We only have a few minutes left, but I thought as another salient question, because I think the landscape will change, even more moving forward because of COVID and the need to continue to work in the virtual landscape. But how have you strengthened, or what have you learned about the possibility of strengthening your international collaborations in the era of virtualness, or the era of COVID?
That's a great question, Allie. I think the first lesson of COVID in international collaboration has not been so much about technology or teleconferencing, although that comes next. It's one of grace. The pandemic has impacted, I think, every human on the planet, at least everyone that I'm aware of. And for most people, increased the stress, the demands that are on each of us. And so we often set big targets and try to move forward and push towards them, and that's important. And so is graciousness with ourselves, gentleness with ourselves, and gentleness with our friends, colleagues, families, partners, collaborators. I think the second concept is, this has been a heyday, if you will, for organizations that were already creating platforms that we can share and collaborate without physically traveling. We're probably saving funds on air travel, and we can be more creative for how we share content, we share ideas, whether it's verbally like this, new platforms for sharing organization and work, anyhow, to be honest, I feel like I personally am at the just starting to discover what can we do there. The knots story that I told in the midst of this, before the pandemic, as we thought about how does this, as the group started, how can this scale? Well, there needs to be something that is online, virtual platform. And yet we still need this human connection to really learn. Humans don't change their behaviors from listening to a lecture. We change our behaviors from having interaction and dialogue. It's how we're going to solve problems of racism. It's how we're going to solve problems of neocolonialism. It's through relationship. And so we need to sort out how do we generate genuine relationships, even if we're not always physically in contact. I don't have the answer to that, but I think that's an objective.
Thank you. I think that's a really kind of humble response, which I'm not surprised to receive from you. I know it's time that we move on to our next moderator session. I want to thank you so much, Robert, for joining us. I think that the effect that you've kind of, and the relationships that you've created at international, national, and local levels in so many different countries are really great lessons to be able to learn from, and something we want to be able to emulate here at Emory, in which we already do in some contexts. So thank you again for joining us, and we're happy to move on to our next panel moderation session.
Wonderful. Well, thank you, Dr. Linden. Thank you, Dr. Roser, and everybody who organized this conference. And for everybody, wish you a great couple days in the conference. Lots of listening to each other and learning from each other. Thank you.